And now Gina Woods and Bob Marcus are going to be moderators of this session, and I'll turn it over to Bob.
Thank you. I just want to indicate that the term open mic does not refer either to Lewicki or McClung. The word is microphone. Yeah. So the floor is open. We don't have any questions yet on the chat line, do we?
Actually, there are two already in the
Two
chat.
already. Let's hear them.
First question is, for patients with a T-score below -3 after completing 12 months of Romo, would you do 6 or 12 months of denosumab and then go back to Romo?
Let me work at that first. An underlying point is that the bone density response to any treatment is predicted by the level of bone turnover when you start treatment. If you have a patient who on denosumab, the most potent inhibitor of bone turnover we have, whatever you use as the next follow-on drug, the bone density is going to be very small. And in the studies we did with the transition from 1 year of denosumab to romosozumab, there was a very small increase in lumbar spine density and no change in the hip density. If at the end of a year of romosozumab, I'm pretty sure I want to use romosozumab again, and we know we can do that. In the phase 2 study, we stopped for a year and then retreated patients, and the full anabolic effect happened again. I choose, as Dr. Lewicki said this morning, an anti-resorptive drug that isn't as powerful as denosumab, and I typically choose risedronate because the approved dose of risedronate is not as potent as the approved dose of alendronate, and treat them for 6 to 12 months, and then discontinue risedronate. Remember, the off effect of risedronate is faster than is the off effect of alendronate, and then give them another dose of romosozumab. And then at the end of that time, I ask again, what do I want to do? I haven't yet gotten to a point of thinking about a third round of romosozumab. So typically at the end of the second course of romosozumab, if I'm happy with where the bone density is and have met whatever one's target is, then I think switching to bisphosphonate maintenance therapy makes sense. If I'm interested in having more improvement in bone density, then I would choose denosumab as the follow-on for that course, and then ultimately transition to bisphosphonates.
Michael, it certainly is the case that coming off a potent anti-resorptive drug will limit the degree of response you get to teriparatide, because that requires there to be some remodeling cycles in play in order to promote remodeling.
Right.
But the questioner asks about Romo,
Yep.
which is not is unrelated to what the remodeling status is. It's what the sclerostin status is. So are you sure that the same effect would occur with Romo?
Yes.
Okay.
We know that from Binta's
Okay.
structure study and from the observational studies from Japan.
But
Binta's going to.
Yep.
That's okay, sure.
If I could just
Of course.
maybe make a comment. And that would be, so I totally agree with all you've said. The only thing I'm thinking,
Thank you.
there are now some old studies that have actually only been presented at meetings suggesting that as long as bisphosphonates are available for the osteoblast, they might inhibit the osteoblast response. So therefore, I might use SOL as the intermediate treatment, because then it will be a year ago since the osteoblast mostly were exposed to a bisphosphonate. But that's the only.
I like that idea. With everybody remembering that when ZOL is given, it clears the circulation in several days. So there is ZOL deposited in the bone at the remodeling site, but a year later, the remodeling sites are somewhere different, and they have new, very fresh osteoblasts, don't they?
Anybody else?
Yes,
Okay.
For patients on dialysis who have received anabolic therapy, would you follow that anabolic treatment with risedronate every other week, or any other suggestions?
I have no idea, and I contend that no one knows that idea. Paul Miller probably is the person who's most apt to give an answer. about that. So, nobody knows what happens when an anabolic drug is discontinued in the context of dialysis. So, do we even need an antiresorptive drug? We don't know. So,
Paul, do you have an opinion on this, please?
in the meantime, let's have another question while Dr. Miller meanders.
No, Paul can do it.
Yeah, there's no evidence. It's just, but I use low dose citrate with the idea that, if I don't do anything, the new bone that's been formed with an anabolic agent is going to get lost. And therefore I'll do something. Take
Do
2
you
years.
know
of-
that in patients on dialysis? I mean, we know
I-
that in the regular patients, but.
Yeah,
All right.
I've used anabolic. I've used, not Romo yet, but, in the old days, teriparatide or baloparatide. And people who, even have mild secondary hyperparathyroidism, but the bone disease that they have is probably adynamic bone disease from biochemical profiling. And I need an anabolic agent to do that. And when you measure P1 and P in these people, even let's say with a baseline PTH of 120, giving them which is high, a little high, they'll still get an increase in P1 and P. Theoretically, from the pulse delivery of the PTH to the osteoblast receptor, in contrast to the chronic high flow. But like you said, there's no data.
To address the question, I think you and I both agree that we're not reluctant to use bisphosphonates in patients on dialysis. We know it's contraindicated, but when there's a rationale to prevent the loss after an anabolic drug, to use a drug and residronate makes good sense, or one dose of Zal. One dose of Zal will probably last for eternity
Yeah, long
in a
time.
patient on dialysis.
Yeah, I think that's right.
Okay, there was a questioner trying to get through Paul here to the microphone.
It's a different case, so.
Okay, it's a new question.
Okay, so this is advice on a case. I see a 61-year-old female who comes to see me for osteoporosis. She has a history of osteogenesis imperfecta. Her history is also significant for breast cancer, estrogen negative, but got radiation therapy. She's had multiple fractures, arms, legs, spine. She continues to fracture. She has received, and her lowest T-score at the spine is -3.3. Left total hip is -1. Hip frac score is -3.7. I mean, she's at very high fracture risk. Cost is somewhat prohibitive and she can't get Evenity. But even if she could, I guess I don't know what is the next step? I don't know what to do.
If she didn't have osteogenesis imperfecta or breast cancer, what would you do? I would do the same thing that you would do if she didn't have OI or breast cancer.
And then if cost is prohibitive and she can't get,
Well,
I mean,
then you can only do what you can do, of course.
and so in a situation like that, I know what the guidelines are, but how, in your experience, how many years do you give zoledronic acid for? I mean, I know they say 3 years and take a holiday, but if somebody has high risk, you can continue it, but how many more?
That we're about to see the 20-year data where zoledronate is given once every 5 years that maintains bone density over that interval of time.
It goes on Medicare. Give her Romodan.
But
She
maybe also
gets-
something
takes the
to
cheap
consider
insurance, it's her
in
fault.
that patient could be denosumab, because she has that very low BMD, and you're not gonna get her close. You know, it's unlikely you're gonna get her close to -2.5 or -2 or whatever could be your goal with a bisphosphonate, irrespective of it being OI or osteoporosis. So, but of course you would need to talk to her about that, because that would. She's not that old. Of course she had her breast cancer, but she could still live many, many years, hopefully. So you will also have to talk about that. Eventually you might want to discuss discontinuation of denosumab and what that entails of, a little bit of extra work.
Question over here on the left.
Yeah, the dreaded patient that comes in who's doing relatively well, elderly, 70s, on DMAB, T-scores close to -3, and sees a dentist and decides that they need to do extensive dental work. And so this patient's not going to be able to do anything for a year. And that and she's been on DMAP for years. So if I put her on teriparatide, chances are I'm probably not doing very much. Romo has on the label that you're not supposed to give it. There's a risk of ONJ. And so therefore the patient, the dentist will go crazy. So often we just say calcium, vitamin D, and take your chances. Now, I have given people raloxifene, but I'm probably doing nothing. So everybody's take on that.
Well, let me refer you to the oral and maxillofacial surgery position statement updated just last year, which makes it very clear that we should not consider stopping denosumab in patients who are about to undergo invasive dental procedures. They acknowledge and appreciate the risk of vertebral fracture if you discontinue. You can't switch to teriparatide. That's not a transition that works. So even in their guidelines, they suggest that the procedure then be done at the 3rd or 4th month after the dose of denosumab, when you're past the maximal inhibition of bone turnover and it's on its recovery phase. And then if things go well and the tooth extraction or the implant heals after 4 to 6 weeks, that will have happened before it's time for the next dose of denosumab. They spell that out in their guidelines explicitly, clearly, and that's a very useful document to give to the dentist who doesn't understand how this should be managed.
We've done that, but it still doesn't seem to
Well,
help.
then you need to find a different dentist.
So can you hear me? John.
We can hear you, John.
No.
Go ahead.
I just wanted to add to what Mike said. Just remember that the every 6 month recipe for DMAP has a little bit of variance here, and you can stretch that out to 7 months. The clinical trial allowed people 5 to 7 months. So if there needs to be extensive dental work, the end of the 4 months, 5 months, 6 months, and then you buy another month, and then you'd go ahead.
Okay. Sir.
I'd like to address this to Dr. Bilzikian. Yesterday, I thought, or did you say that when you're using anabolic therapy, rather than use an interval to decide when to stop, you would recommend that we use bone markers and look for biological activity?
Yeah, that's what I said. Do you want me to amplify?
Yes, please.
Yeah, the point I was trying to make was that these anabolics have an inherent life or biological life that is dependent on the individual, and to say 2 years or 1 year or 3 years for everybody doesn't make a lot of sense to me. If you want the anabolic effect, you would want it for as long as you can have it. And the best way of determining that would be to use bone markers, because there's going to be ultimately a regulation, an internal regulation of that anabolic effect so as to have a downturn. When you start to see that downturn by measuring bone markers, that would be your signal to transition.
Okay, well, when do you start looking for that effect with markers? What time?
Yeah, thank you. Well, we're going to use these drugs for at least 2 years. So I wouldn't, unless you're in an academic center or have a certain curiosity and it can be covered, I would say 2 years would be the time I would begin to track the bone markers.
Okay, thank you.
Can I just make a comment, or can I just ask you, John, maybe this is Bente Langdale, because when I look at the biopsy data from the FRAME trial, where they did biopsies after 2 months and after 12 months, it looked as if there was still bone formation going on at the cortical site after 12 months, despite P1 and P being below baseline at that point. So I'm just wondering, it might be different with teriparatide, but at least with Romo, I think we can be fooled a little bit if we think everything can be seen by the bone turnover markers.
Yeah, that's a good point, Bente. I don't, Bob, Marcus, you might have some thoughts about that in terms of teriparatide, there clearly is going to be a downturn in markers, and you're asking whether on biopsy there would still be evidence of effect. Bob, I don't know for the anabolics.
Well, for the shot study, the anabolic activity continued well beyond 2 years. But I don't even know that they monitored sequentially all the markers to be able to make that link. But yes, the markers will have gone down some degree. They won't have dropped off to this degree that Romo does, but they will have dropped a bit.
Yeah, well, let me agree with both John and Bente. I think that John's approach of using markers to determine the duration of teriparatide or abaloparatide therapy makes sense, but it's more difficult, I think, to apply that strategy for romosozumab, where the dynamics of P1NP are quite different. If you measure P1NP just before the next dose, it's uniformly low. If you measure it a week after the dose, it's often higher. And so one has to be really thoughtful about interpreting P1NP levels in patients on Romo.
There's a question in the chat for Dr.
Yeah.
Clark.
Could I follow up on that a little
Oh,
bit?
sorry. Go ahead.
I think we need to think a little bit more specifically about how we use bone turnover markers for different purposes with different drugs. For example, if I start somebody in teriparatide and I want to show the patient that they're having a nice anabolic effect, I'll get a baseline P1NP and I'll repeat it 3 months later. And then if there's a nice increase, I can tell the patient they're having an excellent drug response. And even if bone density doesn't increase very much after a year or two, we have some evidence that the medicine is doing some good. With abaloparatide, I tend to check it sooner, about 1 month. And with romosozumab, I typically never check bone turnover markers. But if I did, I'd probably get a P1NP 2 weeks after starting it. Now, another reason for using bone turnover markers is to decide if you're going to use the drug longer than the allotted time. So if you've completed 2 years of teriparatide, the patient's still at high risk, and you're considering extending it more than that, you might want to measure a P1NP at that point. If it's still high, that is encouraging evidence that it's worthwhile to continue it. And if the P1NP is back down to baseline, there's probably no point in continuing it behind 2 years. So I think we need to think very specifically about which drug we're talking about and what the purpose is of measuring the bone turnover marker.
Yeah.
Okay, you start teriparatide, you get a follow-up P1NP 3 months later, and it's done zilch. What do? Well, you could ignore it and just continue your teriparatide. We've discussed this in ECHO from time to time. There's some of us who have been able to increase the dose and double the dose on teriparatide. And in some cases, that's actually produced a more profound anabolic effect. Hard to get by insurance, and it means 2 injections a day, but that's a possible strategy for doing that. I'd love to hear what other people would do.
Particularly for people who've been on bisphosphonates, it's not unexpected for the P1NP not to be high at 3 months, and it takes longer for the anabolic effect to be observed. So I wouldn't necessarily increase the dose, but would wait and then remeasure it at 6 months, and it's more likely to be increased at that point.
So I would agree that there might be a delay, and I think it's dependent on the pre-treatment level of bone activity. If there's a low bone turnover state and you start an anabolic, the P1NP is not going to go up immediately and may take 6 months. On the other hand, if someone is in a high turnover state and you start teriparatide, within a couple of weeks, you're going to see a change. So I think a baseline sense of bone turnover is going to give you some sense of how quickly the bone markers are going to change with these anabolics.
Dr. Bilezikian, there's a question about baseline P1NP. predicting benefit of osteoanabolic agents? So you just said it will predict the rate at which the markers increase. Does it predict the fracture risk reduction?
Yeah, great question. I don't have that information. It is certainly true. The higher the baseline rate of bone metabolism with these anabolics, the quicker you're going to see further changes in bone turnover and bone density. But I don't have any information about whether that correlates with fracture reduction.
Dr. Chen's paper, he looked at something that did not predict fracture outcomes in the pivotal fracture trial with teriparatide. I've forgotten whether it was markers or change in bone density. Remember? Anyway, there are some data about changes in markers.
I think it was the marker.
I think so too.
Yeah.
And and I've forgotten whether it was baseline markers or change, but there is a paper by Dr. Chen who looked at that question.
Yeah, as I recall, that study showed that an increase in P1NP at 3 months predicted an increase in BMD at 1 year.
I don't know that any of the studies that have looked at this question address what John Bilozikian just said, and that is, has the patient recently been on bisphosphonate? And I think that's a serious flaw in those studies, because people may be interpreting the lack of response in the wrong way, without taking into consideration what the baseline state of turnover is. Anyway, do we have more on the Zoom call?
We have a lot of questions in the chat. Can we move on from bone turnover?
Yes.
Okay. Question for Dr. Clark. Assuming you start hormone therapy at menopause, it doesn't say why you're starting it. Is there an age at which you would stop it?
So the hormone guidelines from the Menopause Society say the following about that there's no reason to stop at a particular point, and that at every year or so while patients are on therapy, one should reassess the reason you're treating them, the risk-benefit profile of the patient at that time, and make a decision about ongoing therapy. As I showed you from the SWAN study, after 13 years after the final menstrual period, 25% of women were still having hot flashes. And there's another study that looks at older Swedish women, and 8% of them were still having hot flashes in their 80s. So there seems to clearly be a subset of women who have hot flashes forever and may need estrogen therapy. I would switch to transdermal after age 60 if I could convince the patient to do so.
What if you were starting hormone therapy purely for bone health?
I don't think there's a difference in terms of starting for symptoms versus bone health. It's just that no one in the menopause world has really gotten around to thinking about that like they should or could.
So I have a question about your answer. And my question is, you said consider switching to transdermal at age 60. Why would you not begin with transdermal? The human ovaries secrete estradiol into the systemic circulation, not into the portal circulation. Why would anyone want to administer an estrogen into the portal circulation and increase thrombotic risk?
I agree with you completely, and the reasons for not doing that would be cost, that transdermal preparations cost more, and patient preference. Some women react to the adhesives in the patch or don't like them, and so some women won't use them. There is a gel and a spray that's also transdermal, and the gel, Divigel, just became generic in the past year. So now we finally have a lower cost transdermal in that way. And I agree, when the option is available to use transdermal, I think it makes sense because you have lower thrombotic risk. The KEEPS trial looked at oral versus transdermal, and didn't find as much difference as they might have expected, but the women were very young and very healthy, and so it might have been just too early, too small of a trial to see the difference that we know happens in terms of coagulation.
So why would one not initially prescribe an estradiol gel or the estradiol spray? Insurance companies prefer that for cost, and patients prefer it because with a patch, there's something to feel, there's something to fall off. But with a gel, there's nothing to feel and there's nothing to fall off.
Well, the spray is still branded, so it's $150 to $200 a month. Estradiol tablets are $8 a month, and so the cost difference is huge. Patches, again, this is me looking at GoodRx, so I'm sure the prices are really all over the map. Patches are typically $20 to $30 a month. When I last looked at Divigel, it was $50, although I expect it to come down as time passes as it's generic.
But insurance companies cover that.
Sometimes.
So I have I take care of many patients who have panhypopituitarism, and many are of premenopausal age, and insurance companies always cover a gel or the spray.
I just wanted to comment with the thing going on between the two of you. I have sometimes you can give sublingual pills of estradiol and it'll dissolve sublingually, and then usually most of it will bypass the first pass metabolism.
Are those compounded sublingual?
No. The same one you prescribe, like we prescribe normally, orally, you can ask patients to put it under their tongue and it will dissolve.
Do you know if there are estradiol serum levels with that?
Yes. So how I know this, we have a transgender clinic and that's what we do. And we measure the estradiol levels and we follow them, and we keep the pre-menopausal trans woman estrogen levels around the same range as a premenopausal woman, cis woman. And so we follow them and you get the levels appropriately. Even in the postmenopausal woman, we mimic those levels too in a postmenopausal state, and you get the levels you need, and it is sublingual.
Oh, how many times a day are you dosing it?
Once.
Can you refer to any studies that document those levels?
I am going to look for it, and I can. Thank you. Thank you.
So the levels shoot up like really high, though, I think is the problem. So Jenna Sarvedo has a paper on this. I think it's an endocrine practice, and this is in trans women, where they actually looked at the pharmacokinetics of the 1 milligram sublingual, and they get way super therapeutic. And then in the trans population, the problem is you actually don't get the testosterone suppression that you want, because you basically get this pop of estradiol, and then they're actually not getting their testosterone suppressed for a lot of the day. So we actually don't do sublingual and do a lot of patches, but the sublingual pharmacokinetics are, yeah.
I think I need to do a study on our population because we get good testosterone suppression.
It just depends what time you check. Sometimes you have to do it twice a day and stuff. But
all right.
Right. So I think we all agree that when given the choice, we would choose a transdermal preparation of estrogen. At least have that be the first recommendation, and then the patient, of course, helps make the decision.
Question?
I have a case that I was hoping to get Dr. Langdahl's input on. It was a transition off long-term denosumab that went catastrophically, and I am hoping you can give me some insight for the next time, maybe. So this was a lady that was followed by Steve Petak for many years, and Steve had the good fortune to retire before transitioning off denosumab, so I was lucky enough to have to do it. But in any case, she was managed locally by a specialist in Austin before coming to see us in Houston. So at the age of 54, she was treated with Actonel for about a year. Her initial T-scores were minus 3.3 of the lumbar spine, and the total hip was minus 2.9. So this was, fairly significant numbers in a young woman postmenopausal. So at age 54, she had a year of Actonel. She took a year of Evista after that. She took 2 years of Forteo. And then that was followed by 2 years of Vivista, at which point her bone density continued to show that the lumbar spine was not really all that better considering all of the treatment. It was minus 2.8. The total hip had improved to about minus 2.6. So at that point, Forteo couldn't be used again. You know, we had no other anabolic. So in 2012, she was started on Prolia. So she received it every 6 months on a May-November schedule, pretty strict to that until May of 2023. So last May, she decided that she no longer wanted to be on the medication, and she thought that 10 years was plenty. And her scores had actually improved by that point. The spine was minus 2.2. The total hip was up to minus 1.4. So looking pretty good. So I think I called and texted Steve, and we sort of, and I looked at the SORTI paper from 2021, and I basically decided that 6 months after the final Prolia, which was May 2023, I gave her a dose of Reclast, which was November of 2023. So she got 5 milligrams. I checked her CTX in October. It was less than 50. I checked it in November prior to the dose of Reclast. It was 109. So still, you know, very well suppressed. So I think that was mistake number one. I think she hadn't yet started to have osteoclast reactivation, and perhaps that was sort of like the first error. But nonetheless, I gave the dose of IV Reclast. At that time, 3 months later, her CTX, let's see, CTX went up to 419, which made me a little worried. So I actually, at that point, checked again 6 weeks after that, and it was 1100. So I then had a big fight with the infusion center, who said they would not give her another dose of Reclast. And did I know that I had already given it? And I said, yes, her creatinine's normal, and it's the cheapest drug. So I have no idea why this happened. But I finally spoke to the medical director of this infusion center. They gave her another dose, and her 4 weeks after that, her CTX reassuringly came down to 153. At which time we repeated her bone density. She lost 10% at the spine, 11% at the total hip. So she is almost back down to where she was, despite the 2 doses of Zol. And she just did labs, and her CTX is now 600, which is another 3 months later. So the patient is now 68, and I wonder, does some of this, her osteoclasts are extremely healthy. Does some of this have to do with the fact that she was very young at the time of initiation? The duration was quite long. It was 11 years. What should I have done differently? And I kind of think I should just put her back on denosumab at this point. She never had any dental complications. She did have some prior bisphosphonate, which would have made me a little worried about AFF and ONJ, you know, if you're looking at cumulative risk. So this was a catastrophe all around. And I wonder what to do, if anything, differently for her, and what your thoughts are.
Well, so my thoughts are that you actually started out the right way. And I've discussed with other participants here at the meeting that maybe in some cases, like if you've been on DMAP for 11 years, that maybe you shouldn't even wait until the 6 months time period. Maybe you should start even earlier, because it just takes off like crazy. And especially when you've been on the treatment for so long, there's so much rank ligand lying around, and there are no osteoblasts to help out with anything at all. So you either, so I don't know if she could be a case of where it could actually be interesting to try the de-escalation of DMAP a little bit before going in. But I have no evidence to back that up. It's just speculation. But otherwise, I think you would just have to be more aggressive with Reclast, because I mean, 5 milligrams even every 3 months is like small doses compared to what they do in cancer treatment, which is kind of, you know, it's the same aggressiveness we see in patients who've been treated with DMAP for so many years as we may see in cancer.
The whole discussion has been about zoledronate. Is there no role for oral alendronate, beginning it, 4 months after the last dose. So that as remodeling wakes up, then at least they're getting their weekly dose of alendronate. Is that not an option?
I think it could be very, very interesting to investigate, and you might even have to go for the double dose, in 140 milligrams every week or twice a week or something, a higher oral alendronate dose. But somebody needs to test that out, because for the moment it's only speculation if that could do the job actually. But definitely the ones he is very young. That's also what we've seen in all the studies. The younger the patients, the more aggressive the rebound phenomenon is.
Would you care to speculate about whether alendronate would work?
Well, I think it will work.
Okay.
But you know, we've thought so many things that prove to be wrong. So
No.
I don't like to see it.
No.
Oh yes, we have. So, but with the knowledge we have, be more aggressive with, and maybe even monitor more closely than every 3 months if
Right.
they've been on DMAP more than 10 years, because there will be a huge response to that. So yeah.
I think hearing what you said, I would definitely do that. Maybe dose the first reclass, like you said, maybe 3 months before even, and then, you know, who cares, right? Alendronate's free. Just have her start taking that too, because, you know, if you have that much turnover, you're not going to be at risk for ONJ or AFF, right? We're just trying to tamp that down. So this was a very huge rude awakening for me. And, you know, the patient's happy. I mean, she honestly is like, great, I'm the same as I was 10 years ago. I mean, and I'm, you know, like screaming, like, hi, right? I was like hiding under the table when I saw that DEXA scan, but she was okay with it, you know? So I think, and now there's 2 more anabolics, right, on the market that she never had the advantage of having. Yeah.
At this
Thank
point.
you.
Thank you. You have some more. there,
Yes, I do. Okay, a case of a patient who's been on bisphosphonate therapy for 2 years. Their T-score went from -2.7 to -3.0 during that time, but the change was read as not significant. Are they now at very high risk, and would you change them to an anabolic?
So first of all, I will have a talk with that patient about compliance and how this is all going. I would, if I could, measure bone turnover markers to see if they're suppressed, as I would expect them to be on an anti-resorptive treatment. I would, of course, check if there's other things like vitamin D deficiency, if there's weight loss, if there are other reasons for why. Because I know it's not a significant bone loss, but that's not what you want to see on a patient on treatment. So I really investigate, and if I really cannot find anything I can change, the bone turnover markers are suppressed, I would consider changing treatment.
And of course, we check the quality control of the bone density tests and things like that. So again, the patient needs to be reevaluated, and this is one of the situations where I think markers are really helpful. If the markers are high, then you are quite sure that there's either non-compliance or malabsorption, and that would then push you in the direction of perhaps a parenteral antiresorptive drug if that were the case.
Paul?
Throughout the entire 2 days of this great symposium, I continuously hear people talk about T-scores going from -2.7 to -2.4. The ISCD certification courses does not approve monitoring with T-scores. You monitor with absolute BMD and gram per square centimeter, because that's where you do your precision studies with.
We understand that, but real doctors don't know about bone density numbers.
But our job is to teach real doctors.
I don't think we want to have people have to know what a lumbar spine bone density of 1.04 means. They always think in T-scores. We all agree that if you're going to ask whether a change in bone density is statistically significant, that needs to be predicated on the bone density BMD value, not on the T-score.
Right, but the comment was made that was significant, that T-score change was significant, and that's their own statement.
Right.
Yes?
Irene Stancho, Denver. Coming back to the bone markers and treatment with denosumab, I'm just curious if you really have to stop treatment with denosumab after 5, 6, 7 years for a very serious thing. I don't know. Just sometimes it's not serious in my opinion, but it's in patient's opinion. What do you think, all of you, if you have teriparatide or abaloparatide on top of that, like just to mimic a little bit what Dr. Kosman did, like 3 months after last denosumab, I put them on teriparatide or abaloparatide, overlap for about, I don't know, 9 months, like in her study, and then try to switch to the zoledronic acid. Anybody kind of have any thought process in trying to avoid that significant decrease in bone mineral density? Because I would be shocked 10 years to treat patient and then be in
Being on teriparatide will not mitigate the rebound in bone remodeling. Remember, teriparatide increases bone
but
restoration.
on top of denosumab for 9 months, and then I don't do another denosumab.
No, right. But then you discontinue denosumab and she's on teriparatide. And at that moment, she has no protection from the rebound in remodeling. So if you give her ZOL dose 6 months after the last DMAB dose,
Yes,
then
okay.
I'm not sure what teriparatide is doing on top of all that. But
How about abalo?
I think there wouldn't be a difference between those. That they're so similar. So I'd be very interested if you tell us next year what happens when you do that.
I don't know.
But I'm usually quite happy to speculate about things, but this is one situation where I would not be able to predict what would happen. So
Thank you.
Next question over on the left.
Ann McKay, nurse practitioner at Shoreline Orthopedic in Holland, Michigan. My question is related to bone markers and zoledronic acid. If you start if a patient's had ZOL, but you started them because they had osteopenia with high FRAX scores, and a year later, they've improved their bone density, they're still osteopenia, can't use their FRAX scores, for the way it's supposed to be. Do you use CTX to kind of monitor that? Is there any protocol for that to watch their CTX climb before you choose your next time to be reclassed?
I don't know of any specific protocols. I know of people, and Mike maybe talk about what he's doing, but other people are trying different things out with different intervals. I would maybe think that if I've made the decision of treating, I would probably give 3 years in a row of ZOL and then maybe go on a holiday. But I know Mike might be able to talk to that others have a different approach where you stretch the interval between ZOL.
I tried using markers when ZOL came out and got totally frustrated because it could never make sense about that. So I think it's very clear from, again, studies from New Zealand and other places that ZOL does not have to be given every year. Even in the Horizon trial, patients who got 1 dose and followed for 3 years had substantial reduction in fracture. And for a patient who has osteopenia, the objective is to maintain bone density. We're about to see the 20-year data from New Zealand where they gave 1 dose of ZOL every 5 years and maintained bone density over that interval of time. So in a patient like that, I would give them a dose of ZOL. I rarely give a second dose except in the special context of discontinuation of denosumab, and then monitor their bone density rather than their markers. And if and when there's a drift down in bone density, consider at that time giving them another dose if you're in a phase of maintenance therapy for the long term.
Okay. Thank you. It's helpful.
Question at the microphone.
Yes, Ann Malbus from Corpus Christi, endocrinologist. I know it looks like the theme here is like the challenge with patients who've been on long-term DMAB, bone turnover markers, and it looks like what we've been doing is putting them on anti-resorptive therapy. Now, I know the data trial looks at really treatment-naive patients, but has anybody looked at overlapping or doing both DMAB and PTH receptor agonists for an interval period of time and then maybe transitioning off of that afterwards on patients with maybe more than 3 years of DMAP?
No. There's a recent study from Italy where romosozumab was added to DMAB with additional increase in bone density, but then they don't get to the point of what to do at the end of Romo yet.
So that will be an interesting study to do.
And just a comment, maybe, actually, I think it's 40% of the patients enrolled in data was actually has been on previous treatment with bisphosphonate.
Right.
So we usually think of them as treatment naive, but 50% were actually not treatment naive.
Okay, thank you.
Lynn?
So I have two parathyroid questions, one hyper, one hypo. I can just do one if you want. But so I have a 73-year-old woman just saw with primary hyperparathyroidism, urine calcium 300, no osteoporosis, calcium 11, 11.2 of the highest since 2015. Can I monitor her medically if she feels great? And one of the questions that's related to that we talked about today for calcium, but what's the cardiovascular risk in primary hyperparathyroidism if she doesn't have any other cardiac risks? She's a young 70-something.
Awesome.
I could take a crack at that if you'd like. So she meets one criterion for surgery, and that is she has hypercalciuria. She almost meets another criterion by the calcium of 11.2. You didn't indicate what her bone density was?
Right. So I thought the urine calcium was over 400 for true hypercalciuria for primary hyperparathyroidism, and a calcium over 12. Her bone density is minus 2.2.
Her bone density is minus 2.2 at what site?
At the hip, and she's never fractured, no fractures on spine x-rays.
And what, you haven't had her distal third radius measured?
No.
No. Well, okay. The one of the board questions that I was blamed for having written was that in a patient with hyperparathyroidism, the question wasn't quite the way I'm going to put it. In a patient with hyperparathyroidism, and you had only one site to measure, what would you measure? And the answer is the 1/3 radius, because PTH is going to affect cortical bone preferentially, at least initially, in the course of the disease. So I think we don't know what her distal third radius is. In terms of urinary calcium, you're right about the old number, 400, but that's not the new number. The new number is, because we don't know why we picked 400 5 years ago, and I can't tell you why we picked 250 milligrams for women over 24 hours and 300 milligrams for men over 24 hours, except that is generally what you're going to come up with if you do the milligrams per kilogram. And this was endorsed by Monroe Peacock, so it must be true. So I think she does have hypercalciuria. I think she meets another criterion, perhaps because of the calcium of 11.2. I would definitely do her 1/3 radius, but I think she is, there are medical contraindications, she's a candidate for surgery.
Okay, so I haven't done imaging because I was taught to locate the good surgeon, not the tumor years ago. But now I've changed because I want my patients to have focal parathyroid surgery to reduce their risk of post-op hypopara that I think we're all realizing is a lot more common than we thought. At least I have many too many hypopara patients. So let's say I do her forearm, it's not low. I have her take a low salt diet. Her urine calcium drops to 249, and I do imaging, and there's not a single adenoma. There's multiple, or they're not sure. She feels fine, and I don't want her to have surgical complications.
Yeah. Well,
even with our good surgeons in Spokane, Washington.
No, I understand. So my principle is I would never do parathyroid imaging if I wasn't sure about recommending parathyroid surgery. There's no point in doing preoperative imaging if you're not going to operate. So that's sort of a basic principle of how we deal with patients. the second point is even if she doesn't meet any criteria for surgery, that doesn't mean you aren't going to recommend parathyroid surgery. I have a lot of patients who say to me, and they don't meet any criteria, and they say, Doc, you just told me that parathyroid surgery is easy. We can do a preoperative localization. We can find the gland, usually a single gland, by 4D CT in 92% of the cases. And even if I don't meet criteria for surgery, take it out. And we say, why not? As long as there aren't any medical contraindications. So now
Let's have short questions and short answers. We've got lots and lots of questions that we haven't gotten to.
I'll do my hypo-para.
Yeah, later on. Okay.
I have a question about a man with osteoporosis. I always screen them for hypogonadism, and maybe 1 out of 50 times I actually find it. And what I'm using, tell me if I'm wrong, is a repeat testosterone less than 200. For example, a man has a 110 and repeated at 156. He also has some symptoms of hypogonadism that are kind of vague, like I'm not as strong as I used to be. Is that a reasonable patient to treat? I can tell you I did it, but I forgot to mention he's had a hip fracture and had low bone density. Nothing else in the screen was abnormal except the testosterone.
I agree with you. I think your criteria are good. Of course, the studies that are done don't fit any one patient. The TRAVERSE results that I presented earlier, the pre-treatment testosterone values were 227. Those men did, I didn't present these data, men did have some improvement in sexual function and in mood. But of course they had more fractures. So I think that treating men whose testosterone levels are 227, there's some benefits, but then there are risks. I did mention other risks like venous thromboembolic disease and atrial fibrillation. So I think it's a close call with a testosterone level of 227. But you presented a patient whose values are less than 200.
The average of 2 was around.
And so if the values are well under 200, say 150, and that person has symptoms that are compatible with hypogonadism, I think testosterone treatment is reasonable for that person for several benefits that I think are more likely. And I think the benefits in that situation outweigh the risks.
Would you treat him for osteoporosis in addition to his testosterone? With his history of hip fracture?
Really good question. I think it would depend on how severe the osteoporosis is.
Because
if it's relatively mild, it might be.
He had a hip fracture.
Right.
Which is quite a severe complication to osteoporosis.
Yeah.
I'm sorry, I missed that.
Yeah, he had a hip fracture.
I missed that.
And
Sorry.
importantly, in all of the trials in men, at least with bisphosphonates, denosumab, and teriparatide, the benefit, both in terms of bone density and fracture risk reduction, was similar across the spectrum of testosterone. In the 20% of men in the studies who were hypogonadal, their response to whatever osteoporosis drug was studied was similar to the eugonadal men.
Yeah, so I think it would, because of the hip fracture, I think it would be reasonable to treat the osteoporosis separately.
Right, good.
In addition to the testosterone.
Sure.
Okay, thanks. Actually, I wanted to have him on testosterone for 2 years, then decide whether to use something else, because it might be alendronate, it might be an anabolic. So, but
right.
Yeah, thanks for the help.
Tom Olenjinsky from Geisinger, again to Dr. Bilzekian. if I have a patient 2 years out from parathyroid surgery that was very successful with a good bone density response to surgery, would you have any hesitation at that time to use PTH, or would you wait longer?
Yeah, thank you. So you're describing someone who had hyperpara and was cured, and 2 years later, he still or she has low bone density,
Yeah, very high risk.
and you're thinking about using an anabolic. Yeah, I've had patients. If they've had hyperpara in the past, of course, the use of a PTH analog is very different from the disease hyperparathyroidism. So it's not paradoxical, it's not hypocritical. If they meet criteria for anabolic therapy several years after parathyroidectomy, yeah, I would use an anabolic.
Thank you.
Yes, ma'am.
Another question about testosterone. How about not old patients, maybe middle age or after 25, 30, 35, 40, that come. I know that testosterone on our levels, apparently there are two, like they're normal evidently, but they say it's low for a young person. So I'm asking you, if a young person, a young man comes to you saying that testosterone is low and it's, let's say, 250, 200, 250, so over 200 with low normal LH. Sometime I get a pituitary done and here it is like a 5 millimeter, 3 millimeter, something in the pituitary. I do the workup, exclude a real pituitary disease, but they claim that testosterone is too low for them being young. And I say, I don't agree with it, but I want your opinion.
I agree with you.
Okay.
Great, we'll take it.
I'm not discriminating.
So yes, it's common for men to want to blame. I think that's the right word.
Right.
Well, maybe we could say ascribe instead of blame. Men want to ascribe their feelings of inadequacy in one or more areas, like lifting weights and others, to their testosterone being 350 instead of 750. And you can assure those men that low testosterone is not the reason. I don't know how many of you know that some years ago, two different groups, both Bill Bremner's and Ron Swerdloff's, performed an experiment where they gave a superactive GnRH agonist to young men to make their testosterone concentrations undetectable. And then they replaced those men with testosterone to levels of 300, and then 600, and then 900. And they administered questionnaires before any treatment, and then during treatment at each of those levels. And what they found was that those young men could not tell the difference in sexual function, in energy, in mood, in any way between serum testosterone concentrations of 300 and 600 and 900. Only when their testosterone concentrations were less than 50 could they tell the difference.
What is the citation of that study? Or can
I can't remember, but I know it was done by both of those groups independently.
Peter, do you of getting measurements of SHBG and estimating free testosterone in instances like this?
No.
Okay.
No, unless there is a reason to think that their SHBG concentrations are not normal. But they're not, I suppose if someone were very obese, that lowers SHBG. And I see occasionally men whose concentrations are not normal, but very, very unusually.
And another quick question, how about high SH?
Yeah.
Hi, I'm Kashmira Singh. I'm a rheumatologist from Albuquerque. Thank you for the wonderful presentations. And I had a question. So I see that long-term use of denosumab has this great rebound effect we have seen time and again. So if we have an appropriate patient who, is treated to target in a few years with a T-score from osteoporotic or close to -3 to close to -2.2 or closer to the osteopenic range, is there an advantage to transition them sooner to reclass zoledronic acid if the other parameters permit to avoid that rebound effect from a longer duration of denosumab?
Yeah, if you've reached what you think is an appropriate target for that patient, then transition them there because the rebound is clearly associated with the duration of DMAP treatment.
Thank you.
We'll take a quick question from the chat about bone health in cancer patients. Is there any recommendation for adjusting FRAX for androgen deprivation therapy or aromatase inhibitor use?
No.
Okay, great. There's three parts to this question. Any concern about using anabolic treatment in someone who had a remote history of cancer 5 to 10 years ago?
An antibiotic?
Yes.
There's a theoretical concern about use of PTH analogs if people have micrometastases, but if people are 5 years out and there's been no evidence of cancer, that risk is so remote that it probably wouldn't influence my decision.
And what about Romo?
Romo has no effect on cancer promotion. In the big cancer rat studies, there was no effect at all on any type of tumor.
Great, thank you.
Ann Mass, internal medicine in Colorado. And in the setting of this explosive world of GLP-1 agonists, can you just discuss some data, any emerging data on bone density and fractures, and also concerns about administering drugs orally in patients on GLP-1 agonists?
I don't have any information about the concern about giving drugs orally, and I'm waiting for the studies to look at bone density changes. So as we heard about the other day, most strategies that result in weight loss result in substantial decreases in bone density. So that needs to be looked at and monitored, I think, very carefully.
John, do any of the people in your group who deal with diabetes and bone have any interest or information about those drugs?
Well, no, not yet, but there is.
You're on mute, John.
Oh, no, I'm not.
Oh, well, we weren't hearing you.
I'm sorry. I'm not on mute. Can you hear me?
Now we can, yes.
Okay. No, I was saying that we don't have any data yet, but the diabetes group is obviously very interested and we're starting to work on that, but I don't have any information now.
If I can maybe, because it seems like the effects of these drugs are not all the same. Because there's a study coming out of Odense in Denmark where they looked at Ozempic in non-diabetes patients, and they saw big bone loss, really big, high increases in CTX. And we have given a previous version to diabetes men, and they didn't lose bone. So there seems there's still a lot of questions about the effect of that.
Maybe we'll have a chance to deal with that on the 25th anniversary of this meeting next year. But I've been instructed by the closed mic to close this mic. So thank you so much. This is a great session.